Hello friends, welcome to Raaonline. I am Dr. Vasanth from Critical Care Medicine, Apollo Main Hospital. Today we are going to see on anatomical localization of stroke. I am going to take on that ischemic part, right? So here we have our first patient, a 70 years old male, a known diabetic and hypertensive, developed a weakness of right side of the body and facial deviation to left after he woke up from sleep. The weakness worsened as the day progressed. History of transient ischemic attack around 3 weeks back. No other significant history. On examination, the vitals and higher mental functions were normal. In cranial nerve examination, upper motor neuron type of right facial nerve palsy present. Motor, power 2/5 in right upper and lower limbs. Plantar extensor on right side. The left power is normal and left plantar is normal again. The sensory system, cerebral functions and cranium and spine, other systems are normal. So here we have a 70 years old gentleman who had right-sided weakness and come to us, right? So how are we going to approach this patient? The functional diagnosis is cerebrovascular accident and right hemiparesis. Hope everyone agree with me. So now we are going to place anatomically where does this stroke come from. Either it should be in the cortex or corona radiata or internal capsule or the brainstem, right? Since the patient has a right-sided hemiparesis, the insult should be on the left side of the brain. So the left cortex or left corona radiata, left internal capsule or left brainstem. What if this patient had a stroke in the left cortex? Cortex has its own cortical sensory stimulations. So if the cortex is involved, the cortical sensation at that particular segment of the body will be lost. But in our patient, it's clearly mentioned that cortical sensations are present. So less likely to have a cortical involvement in this patient. So next is the corona radiata. How to differentiate an ischemic stroke, whether it's placed in the left corona radiata or left internal capsule? Kindly have a look at this diagram. If it's going to be at the level of internal capsule, the neurofibers are densely packed in the internal capsule. So any small insult, any small ischemic lesions at this particular area is going to involve both the upper and lower limb fibers equally. Okay, equal involvement is otherwise called as dense hemiparesis. So the term dense actually means equal involvement of upper and lower limb, actually not the severity, right? So what if it's a corona radiata? This segment of the brain is called as the corona radiata. Have a look at this. The corona radiata, the fibers are actually dispersed. So a small ischemic stroke at this region is less likely to affect both the upper and lower limb equally, right? So our patient had a power of 2/5 in both upper and lower limb. This means equal involvement of upper and lower limb. So more likely to be on the internal capsule. Could this be in the brainstem? If this is present at the brainstem, there are brainstem nucleus. So those should have been affected. But it's clearly mentioned that no other cranial nerves were affected. So less likely to be brainstem, right? So we have a cerebrovascular accident patient with right hemiparesis with human type of facial nerve palsy, lesion involving left internal capsule, possibly due to thrombosis. How do we come to a conclusion that this is thrombosis? Either it should be thrombosis or an embolus or a hemorrhage. It's very difficult on a clinical basis to differentiate all these three things, but we can have some clues to point our light towards thrombosis. One is TIA, transient ischemic attack, that occurred around 3 weeks back, and second is this event happened during sleep. So these two phenomena tells us this could be possibly a thrombosis. Okay, then in lenticular striate branch of middle cerebral artery, how do we come to this kind of conclusion? Let's see that in our seminar here. And of course, he's suffering from type 2 diabetes mellitus and systemic hypertension. So this is the arterial supply of brain. Starting from the aortic arch, we can see that the brachiocephalic on the right side gives branches to the right subclavian and right common carotid. And over the left common carotid comes directly from the aorta. It goes up, differentiate into the left internal carotid and left external carotid. And the internal carotid artery bilaterally enters the brain. Okay, can you see this? This part of the circulatory system of brain. So when the internal carotid artery enters the skull, it gets branched into anterior cerebral artery and middle cerebral artery. Okay, I'll just zoom this segment of this picture. So once the internal carotid artery enters into the skull, it gets branched into this segment, which is called as the middle cerebral artery, and this segment is called as the anterior cerebral artery. Okay, so this is middle cerebral artery, this is anterior cerebral artery. Okay, so from now onwards, whichever major arterial connections we are going to see will be divided into segment 1 and segment 2 by its own divisions. Let's have a look on that. So in anterior cerebral artery, this segment is called as A1 and this segment is called as A2. So A1 and A2 is divided by anterior communicating artery. Okay, so A1 and A2 is divided by anterior communicating artery. Have a look at this picture. If there is a thrombus at A1 segment, the patient usually is asymptomatic because there is adequate flow from the opposite side which can supply both the A2 segments. Is it clear from this diagram? If one side is blocked, one side A1 is blocked, adequate blood supply comes from the opposite segment and the patient is usually asymptomatic, right? So what if there is a thrombus at the A2 segment? If there is a thrombus at the A2 segment, that part of brain that is supplied by the A2 goes for ischemia, right? So we should know what does this A2 segment supply. So this is the arterial supply of brain. This is the lateral surface, this is the medial surface. In lateral surface, you can see that the yellowish area, yellowish painted area is supplied by the anterior cerebral artery. And this area is supplied by the middle cerebral artery. And this blue segment is by the posterior cerebral artery. This is the lateral surface of brain. And this is the medial surface of brain where a huge area that's supplied by the anterior cerebral artery and a very, very minimal middle cerebral artery and posterior cerebral artery is the blue one, right? So this is the brain picture. The medial strip which we showed in the previous picture supplied by the anterior cerebral artery and the green by the middle cerebral artery and the little most is from the posterior cerebral artery. Hope you all remember this picture. This is the homunculus. Okay, putting the human body in this upside down area, we can see this thin strip of brain that is supplied by anterior cerebral artery represents the lower limbs and the hip and the trunk this way, right? So anterior cerebral artery supplies the lower limb, hip and trunk. Middle cerebral artery supplies the upper limb, face and the tongue and larynx. Hope you got the point. So now, if there is a thrombus at A1, how will be the presentation? Patient can be completely asymptomatic because there will be adequate flow from opposite side to both the A2, right? If there is a block in A2 segment, what will be the presentation? That segment of brain supplied by A2 will be affected, right? So what is the segment of brain supplied by this A2? This thin strip. Hope you all remember, right? What does the thin strip represent? That represents the lower limb. So for that reason, it's called crural monoplegia. Okay, opposite side lower limb will be affected. Crural monoplegia. Apart from that, it is also the frontal. So abulia, that is lack of interest, dyscalculia, social disinhibition, frontal releasing reflexes will be absent, right? In some segment of population, around 10 to 15%, you will be able to see this small arterial communication. This is not universally present in all the human beings, in only a small group of segment of people. So this artery is called as artery of Hübner. This artery of Hübner starts from the A2 segment and supplies that part of internal capsule that represents the face and upper limb. Okay, face and upper limb. So what if there is a block in the artery of Hübner? Answer is simple. Opposite side, face and upper limb will be affected, right? What if there is a clot here? So this is proximal to this artery of Hübner and there is a A2 block also. Because of artery of Hübner, the face and upper limb will be affected. Because of A2 segment, lower limb will be affected, right? So face and upper limb will be affected by the artery of Hübner. The lower limb will be affected by the A2. So A2 affects the lower limb and artery of Hübner affects the face and upper limb. So clinically the patient will have hemiplegia. What if this A1 segment is congenitally absent? and the opposite, the only remaining A1 segment is also thrombused. How will be the presentation? If both the A1 segment is blocked congenitally or by thrombus, then both this A2 will go for ischemia, right? So, both the lower limbs will be affected. So, patient will present with paraplegia. Coming to the middle cerebral artery. So, this segment is called as a middle cerebral artery. Hope you know this is the M1 segment, this is the M2 segment, okay? This is M1, this is M2. Have a look at this. M1 segment has lot of penetrating branches. M2 usually doesn't have that, okay? So, this is the middle cerebral artery again. M1 has lot of penetrating branches and this M2 segment. And M2 is divided again into superior M2 and inferior M2. So, let's put some brain material into it. Okay, have a look at this. This is a middle cerebral artery dividing into M2 superior and M2 inferior, and this segment is the M1 segment, and this is M2 superior, this is M2 inferior. Have a look at this, dear friends. The Broca's area is here, supplied by the superior segment of M2. Wernicke's is here, supplied by the inferior division of M2. Okay. What if there is a stroke? What if there is a thrombus at the level of M2 superior? Answer is simple. The patient will have Broca's aphasia. Yes. Then this entire cortical material will be affected. So, if this entire cortical material is affected, that segment of the body which get represented will also get affected. So, what is the segment of body that is getting represented by this? It is the face and upper limb. Hope you all remember the thin strip here is by the anterior cerebral artery, that's the legs. Remaining part of the body comes over here, which is affected by the M2 superior division. Okay. So, patient will have Broca's aphasia and face and upper limb weakness also, right? It has to be understood that though the anterior cerebral artery supplies a thin strip here supplying the lower limbs, it has adequate friendship. It has adequate friendship with the M2 superior division also. Okay. The middle cerebral and anterior cerebral has adequate friendship. Even if M2 goes ischemic, there will be some little amount of weakness in lower limbs too. Upper limbs will be severely compromised. Upper limb will be severely compromised because it is a dominant segment of the M2. Lower limb, though it is from anterior cerebral artery segment, still because of significant friendship between the anterior cerebral and middle cerebral, even the lower limb will be mildly affected. So, patient has hemiplegia. What if this is the non-dominant side? Broca's is a speech area. Speech area means it's dominant only. What if this happens at the non-dominant side? Patient will have apraxia, hemi-neglect, visuospatial disorientation and cortical sensory loss. Okay. What if there's a thrombus at the M2 inferior division? M2 inferior division presents with ischemia at this level. So, patients will have Wernicke's aphasia, coordination issues will be there, and there will be some optic tract, visual tract running at the level of the basal temporal region. So, even those will get affected. So, patient presents with Wernicke's aphasia and superior quadritanopia. Okay. What if there is a thrombus at the M1 segment? The answer is simple. If there is a thrombus at the M1 segment, both superior division of M2 is off, inferior division of M2 is off, the entire brain material goes for ischemia. The complete brain material on one side of the body goes for ischemia. So, patient usually will be comatose. So, as we already mentioned, M1 segment has multiple penetrating branches. One such is the lenticulostriate branch that causes hemiplegia. Next, this can affect also the pure motor hemiparesis by the motor fibers of internal capsule. Next is that fiber supplying the thalamus, pure sensory hemiparesis. Ataxic hemiparesis occurs when frontopontocerebellar fibers are affected, and if that branches affects the genu, it's clumsy hand dysarthria syndrome. So, these are some exam questions. M1 penetrating branches, if they go for ischemia, these will be the presentations. And the biggest clue you have to have in mind is, if the cortex is affected, cortical sensations will be absent at that particular segment. If cortex is not affected, if the effect is only at the level of internal capsule or brainstem or corona radiata, cortical features will be present. So no cortical features, no brainstem features, because these are supplied at the level of internal capsule itself. So now, hemiplegia. We said that if there is an artery of Hubner, if both the artery of Hubner and A2, if they get affected, we know the patient presents hemiplegia, right? Artery of Hubner supplies for the face and upper limb, and the A2 segment supplies for the lower limb, right? So if both gets affected, patient will have hemiplegia, right? So we also said lenticulate straight branch of M1 segment also can cause hemiplegia. We also mentioned that M1 segment, if it goes for ischemia, both the upper and lower limbs will be affected. So even this can present with hemiplegia, right? So how to differentiate when a patient presents with hemiplegia, how to differentiate whether it's because of type 1, type 2 or type 3, right? It's very easy. Have a look at this picture. The thrombus is at the level of proximal A2 along with the Hubners, right? Artery of Hubners supplies the internal capsule that represents the face and upper limb, right? If this artery of Hubner is representing only the internal capsule part, the cortex is intact. So the face and upper limb cortical sensations will be intact. A2, this A2 supplies the lower limb, right, at the cortical level. So in the leg, cortical sensations will be affected. When a patient presents with hemiplegia and you go examine him, the face and upper limb cortical sensations are intact. By the lower limb, the cortical sensations are absent. It means that you are handling a patient with possibly a A2 syndrome, A2 block, who has a artery of Hubner also. So what if there is a ischemia at the level of lenticulate straight branch of M2 segment, M1 segment? If this occurs, this completely affects at the level of internal capsules itself. So usually the cortical sensations are preserved in both the upper and lower limbs. Okay. Here, it's even more easy, because if M1 segment is affected, the brain usually goes for gross edema. The brain goes for gross edema, patient usually comatose. Okay. Even if the patient has adequate space in the brain because of atrophy and the patient is conscious enough, then on examination you will be able to find both the upper limb, lower limb are affected at the cortical level. Have a look at this diagram. So both the upper limb and lower limb are affected at the cortical level. So cortical sensations are absent. Get this concept right. Here there's a thrombus at the A2 segment. So A2 plus artery of Hubner. Artery of Hubner goes to the internal capsule, not the cortex. So what does this artery of Hubner supply? The internal capsule representing the face and upper limb. So face and upper limb cortical sensations are not affected. This A2 goes and supplies the opposite lower limb at the cortical level. So cortical sensations are absent. So this hemiparesis presents with face and upper limb cortical sensations intact, but lower limb cortical sensations lost. This type of hemiplegia, where M1 branches from the middle cerebral artery, affects and produces a hemiplegia at the level of the internal capsule itself. So cortex is not affected in both upper and lower limbs. Here in this type of segment, both the upper limb and lower limb is affected at the cortical level. So cortical sensations are absent both in the upper and lower limbs. Hope you know to differentiate these three, right? Now coming to the posterior circulation. So the vertebral arteries join to form the basilar artery, which divides into posterior cerebral artery. Posterior cerebral artery, right? So this posterior cerebral artery is divided into P1 segment and P2 segment by this branch. What is this branch? This is posterior communicating artery. Okay. So the posterior cerebral artery is divided into P1 segment and P2 segment by the posterior communicating artery. As far as exams are concerned, the P1 has some branches which can be exam case for you. So thalamogeniculate branch supplies the thalamus. Hope you know that thalamus is the main sensation area. So patient can have hemianesthesia. Then optic radiation is also affected. So homonymous hemianopia. If your patient presents with hemianesthesia, loss of sensations in one side of the body, and optic radiation is getting affected, then it is actually a posterior circulation stroke. Thalamogeniculate branch. Okay. P1 branches to the midbrain. At the level of midbrain, third and fourth nerve usually is there, right? So third nerve will get affected. Along with that, if the pyramidal tract is affected, patient will have contralateral hemiplegia. If the red nucleus is affected, the patient will have tremors at the opposite side. If the superior cerebral peduncle is affected, patient will have contralateral ataxia. Okay, so when your patient presents with contralateral hemiplegia and third nerve palsy, then you're handling a Weber patient. Tremor with third nerve, it's Benedict's. Superior cerebral peduncle with third nerve is Northern-Hagel. Claude innocent with Northern-Hagel plus Benedict's. And if it affects the subthalamic nucleus, it's hemibalismus. Okay. Next exam questions will be at the level of the medullary area. Pons is actually simple. It just mimics that of the brainstem except for the difference in the nucleus, difference in the cranial nerve nucleus. Otherwise, the medial medullary syndrome and the lateral medullary syndrome are your exam questions. You will receive patients on this also. So, how to remember this? MMS, this is medial medullary syndrome. Do remember that you got an MMS at night 12 p.m. So, this is the way we remember MMS at 12 p.m. Okay, 12 p.m. So, medullary syndrome. If the medulla gets affected, it can get affected either medially or laterally, right? So, this is a medial surface and this is a lateral surface, right? So, you should be aware what are the structures present in the medial area, what are the structures present in the lateral area, okay? So, medially you have the pyramidal tract, so patient can have contralateral hemiparesis. Medially it has 12th nerve nucleus, so ipsilateral 12th nerve palsy will be present, and medial lemniscus, so fine touch, vibration, joint position will be affected or absent, will be crossed. So, this medial medullary syndrome. Lateral medullary syndrome is even more important because in our routine practice, if at all the patient is not having any weakness of upper and lower limb, it's very rare that we diagnose a patient has any type of stroke, right? But lateral medullary syndrome does not have any hemiparesis. Lateral medullary syndrome does not have any hemiparesis, but still he is suffering from stroke, right? So, what are there in the lateral area of the medulla? The sympathetic fibers that produce Horner syndrome, nucleus ambiguous of the 9th and 10th cranial nerve. These are the nerves of the medulla. Spino-trigeminal tract, ipsilateral loss of pain and temperature over the face, and for the body it is the opposite side. So, for the face is the same side loss of pain and temperature, for the body it is the opposite side loss of pain and temperature. And because of the vestibular nuclei, nystagmus, vertigo and vomiting occurs. Because of inferior cerebellar peduncle, ipsilateral cerebellar signs will also be present. So, in lateral medullary syndrome, patients may not have any type of hemiplegia at all. Maybe the only clue might be just hiccups because of nucleus tractus solitarius. Okay, nucleus tractus solitarius is the sensor nucleus of 9th and 10th nerve. Okay, because of that, patient can have just hiccups alone without any weakness. Patient can come to you with walking, talking, but on your examination, if you find there is Horner syndrome, there is ipsilateral loss of pain and temperature over the face and contralateral loss of pain and sensation of the body with vestibular symptoms, then this patient is suffering from lateral medullary syndrome. Do an MRI with MRI and diagnose that the patient is having a posterior circulation stroke. Thank you, dear friends.